going to go ahead and start the recording and welcome our special guest, Dr. Ron Fischler, who is, of course, known to all of us as a member of our Temple community and the husband of one of our past presidents, and well known to all of us, but also perhaps not as well known. I would say the leading voice in the state of Arizona in support of medical aid in dying. And actually, you can tell us about the task force that you're working on and how you came to be involved in that effort. So without further ado, I'm going to turn it over to Dr. Fischler. Please share any other credentials that you would like to about how you became interested in this work.
Sure. Can I share my screen? I can just go through some slides.
I'll have to figure out how to.
I think so. I think it happened. Let's see if I can figure out how to do it. Desktop.
Oh, look at that.
No, wait a second. That's not what I want.
Yeah, but at least you're screen sharing, so that's a start.
Wait a minute. Give me one more second here. Share screen.
Hi, Barbara. Nice to see you.
Hi, I'm going to be in and out here. I got someone here still.
No worries. Glad you joined us.
That is very weird. I'm not sure why that is. Let me do one more thing. It's one of many items on my desktop.
Right. I know how that
I would like to find it. I wonder
yes,
if I
Barbara,
open
just
it.
be aware we're going to.
If I open it first, then maybe that will help. Let's see. And I think one more second. So share screen. There it is. Okay.
Beautiful.
And one more thing, I've got to figure out how to get to the slideshow presentation piece of it. Okay. I think that's going to work. Do you see it now?
Beautiful. Yes.
Okay. So how did I, as a pediatrician who just retired in May, get involved in this topic? I guess it's a few influences. I guess I got sensitized to death and dying when my mother died when I was just a kid. I was 12, and she had languished for a year. There was no discussion about the nature of her illness. She had lung cancer, which I didn't know until she was in the hospital at the very end. So she went to the hospital basically to die. She was there a couple of days and then died. There was no discussion, and most people at that time, with the medical advances of the 20th century, pretty much died in the hospital. Very few died at home, whereas 50 years earlier, the majority of people died at home. So this had been one of those changes. You know, then as a medical student, Elizabeth Kubler-Ross's book on death and dying came out, and I remember being very profoundly affected by that. And then I had an experience as a pediatric resident. I was taking care of a infant on the wards who was now a year old and had never left the hospital. It was very premature, had very immature lungs, and had a series almost daily of dying episodes where he would become apneic, wouldn't breathe, and had to basically be resuscitated. And this is how residents learned how to do resuscitation, was on this kid. And, you know, I just felt there was something that just seemed so wrong about that. And this was long before people knew of their right to be able to refuse all sorts of care. So the family.
One second, I'm thinking we should reserve our questions, let you do your presentation and then reserve our questions. Okay.
Okay. So it was, at that point, we discussed it with the family and with the support of the nursing staff, and interestingly, some resistance from some of the doctors on the case. We simply did not intervene when he had a dying spell, and he died peacefully. But that stuck with me all these years. And then as Bill Moyers had a documentary, you may remember, around 2000, so it's about over 20 years ago, On Our Own Terms was the name of it. And in one of the vignettes in that documentary, he compared how two patients with ALS, Lou Gehrig's disease, progressive weakness to the point of not breathing, and then you either have to intervene or not, died, comparing a patient in Oregon, where they had just passed the law permitting medical aid in dying, and another state, I think it was Florida. And that stuck with me in a very profound way. And then I got to, getting a little older, and friends and family begin to take this sort of road towards illness and ultimately death. I began reactivating that interest. It was medical staff leadership at Honor Health when I was asked to co-chair an effort to look at the patient experience that I made rounds with one of the hospitalists. And it had really been the first time in, 40 years that I had been inside a medical ward in a hospital to see what was going on. And I saw an astounding number of patients, elderly people with advanced illness, who were in nursing homes primarily, who were admitted to the ER and then to the hospital, sometimes to the ICU and home. Their families weren't particularly involved. They didn't have an identifiable primary care physician. While a few had DNR orders, if they stopped breathing, they didn't want to be resuscitated, most had no advance directives. And I began to wonder, how much of a problem is this? And I began reading. I came across Atul Gavande's book, Being Mortal. Many of you have, I think, have read that. And the Institute of Medicine, which had a study from also the same year, 2013, that suggested that we have a lot of opportunity ahead to make care at the end of life much better for people. So that's how I got involved. Then I organized a task force. After I saw that this was a pretty big problem, I wondered about how was it in Arizona. And so with the help of a few other folks who were doing this work, we assembled about 28 doctors from around Arizona. And they were in many specialties. I think 10 or 12 were in palliative care and hospice work. Some were medical specialists. Some worked for insurance companies. So we had a broad array of perspectives: rural, urban, teaching, community settings. And we met for 2 years, and we published a report. And one of the things we did was a survey of physicians. And we had about 600 physicians that we got responses from, and we collated those. I'll address some of those findings in a little bit. But, and these questions were directed at how comfortable they were, how much training they had, whether they made referrals to palliative care, and most importantly, how did they counsel patients when they reached a certain age, when they were diagnosed with a terminal condition, when death was impending? Did they have heart-to-heart conversations with patients? And if not, why not? And we asked about whether they supported medical aid in dying. So I'll come back to some of those findings if you have more questions about them in the question and answer period. So congratulations for embarking on something that most people don't really spend a lot of time thinking about, which is, depicted by the cartoon. Even if I stand in the middle of the room, no one seems to acknowledge that I exist. And yet when you ask people, how do they envision the end of their lives? They imagine something like at home with loved ones, with symptoms of pain and anxiety, discomfort managed, spiritual needs respected, and without being a devastating burden on family. I mentioned the Atul Gavande's key book. There are 2 other books, and maybe after this session, we can share this so you can have access. Barbara Combs-Lee's book, Finish Strong. Many of you were participants in that discussion last year of that book. And Katie Butler's excellent book, The Art of Dying Well. And she's not a physician or a medical person, but more of a journalist who interviewed hundreds of dying patients and offers some practical advice on how to plan the death you want.
We did an in-depth review of an article of hers a couple of weeks ago.
I'm sorry?
We did an in-depth review of an article of hers a couple of weeks ago. This group.
Excellent. Okay. And then Compassionate Choices, one of the major advocates for medical aid in dying nationally, has a toolkit that is called My End of Life Decisions. It's available on their website, and it's very, very good at compiling a lot of information related to advanced directives and planning ahead. And just a few terminology points. Goals of care conversation. That's the conversation that the Conversation Project is all about. And we've done several trainings on that. It's basically to start the conversation with each other, with your loved ones and your families, on when time is limited. What do I want? What's important? What do I fear most? What do I not want? So it's a more general kind of conversation to open the door to the more detailed. The results of the detail should be to define advanced directives. Lawyers call this a living will. And it says, if I'm incapacitated, I'm not likely to get better. And what would I want and what would I not want? And then it refers to specific treatments. And as you become further along this road, and as you get older or you get diagnosed with an illness, the things that you want or you don't want may become much more specific. So it's important to begin this process, but it's going to be refined, updated as time goes on. The other really important thing to do, and you probably discussed this, is appoint somebody, a proxy, a healthcare power of attorney. If you become incapacitated, who could speak for you and your wishes if you can't? This came up very poignantly just a week ago when a person in our Musar group, her husband had a series of strokes over a few days. He'd had dementia for several years and then a devastating stroke. And she was left with having to make some decisions for him. And I called her just to offer help, and we walked through some decision making. And it was quite clear that he had a devastating stroke. He would never return to his normal functioning. So what would he have wanted? She said we had discussed these issues in depth. He did not want to live in a way that would enable him no longer to love his life and the people the people around him. He would not want to live this way. We talked about options, end of life options, and she chose hospice. And then she had to discuss whether it was going to be at home or at hospice. And she made that choice, and it went he essentially suspended eating and drinking, was comforted at hospice, family visited, even the disparate family that had not been in touch or may have questioned this decision came forth as part of the healing process that occurred. And it was a very, very smooth, very sweet family experience to bid him goodbye. A few other things. POLST. POLST is Physician's Orders for Life-Sustaining Treatment. It goes by different names in different states. It has not been in widespread use in Arizona, but Arizona now participates in the National POLST Network. POLST translates your medical wishes, your living will, into a set of doctor's orders. It's appropriate near the end. So in the last 6 months of your life, this specifies what treatments you will have, what treatments you won't have. And it's transportable, meaning if you get admitted to the ER, the hospital, the ICU, it follows you. Arizona has this orange card, which is designed for first responders to know whether you wish to be resuscitated. And it's supposed to be displayed on your refrigerator. So again, this is sort of last few months of life, something to consider. Living wills, orange cards, all those things can be stored at the state site. It used to be with the Secretary of State. I think it's moving to the Health Information Exchange. But mostly it's important to have it accessible to you, to your loved ones, to your doctors, and so forth. Palliative care refers to a new medical specialty. It's only about 12 years old. And the purpose of palliative care is to help you navigate, to help you initiate these conversations that might be difficult for some of your doctors, as we'll get into in a minute, and to help you navigate which treatments should I have, should I not have, that are consistent with my goals. So it starts with the goals of care conversation, becomes more specific, and you may engage a palliative care specialist to help you. Because all too often, as many of you may have discovered, doctors are reluctant just as we're reluctant to have these conversations. They're reluctant to initiate these conversations, and they mostly perceive that people aren't ready for these conversations. And they're quick to offer another treatment rather than sit down and say, what are your goals here? This is where we are in the course of this illness. So palliative care is helpful to navigate. And then hospice is a place that provides comprehensive end-of-life care designed for the last 6 months of life. It includes medical services, social services, and support services. Most people in hospice prefer to have home-based services, so receive these services at home, and some at a facility like the Eckstein Center or the facility at Mayo, or basically facilities all over town. And you're going to be hearing a lot more about hospice from a real expert, Deb Barrett, next week. I think it's important for people to recognize that unlike 120 or more years ago, most deaths don't happen suddenly, and most deaths now involve a chronic illness. So you're diagnosed with an illness, and then the time between diagnosis of the illness averages about 2 years. It can be a lot quicker than that, it can be slower than that. And so the question, the existential question for all of us is really, how do we want to spend the time when we know our time is limited? Do we want to use all of that time fighting for more time, i.e. aggressive care that might make us a whole lot sicker? Or do we want to live most fully in the time that remains? What are the trajectories for the illness that I have or have been diagnosed with or might be diagnosed with? Is it sudden? Does it continue along and then fall off a cliff? Is it more gradual? Is it stepwise? And really, you need advice from your physician on this if you can have this conversation. In Being Mortal, Gavande talks about the kinds of communications that people have with physicians. And I guess you have to ask yourself, how do I communicate, or how would I like to communicate with my doctor? Do I want you to tell me everything so I can decide? I maintain control, you are an information source. I don't want to be told anything, you decide what's best for me, which is the old paternalistic, certainly our parents' generation, grandparents' generation, certainly had that. Or do I want some combination? I want the information, but I also want your guidance and expertise based on what you've observed other people with similar situations experience. I think many of us would like that. What's the diagnosis? What does that mean? What does prognosis mean in terms of what is the average? What's the range? What's the minimum? What's the maximum? And what's the trajectory? What's the course likely to be? This part of the conversation is rarely done. Risks and benefits of each of the treatment options so that you can decide, does it match your goals, meaning quantity or quality? And will treatment affect the quality or quantity of life? And it's good to take someone with you. It's good to take notes or record that conversation or conversations. And it's good to involve your primary physician because he's knowledgeable about the medical system and about, he may have a different perspective knowing you than maybe some of the specialists you've been referred to. So now we're going to focus on what are the legal end of life options. So you can follow all treatment recommendations right to the end. So you can fight the disease to the very end. That is your right. You can get on experimental protocols and so forth. For some, this is what they do, and that's okay. And then they check into hospice in the last day or two and pass there. Certainly that has been the default for a lot of people for a long time. I think more and more of us are questioning whether that's the approach that we want. In contrast, you can discontinue or refuse any or all medical treatments, and you can decide which ones. And ideally, you should base that on information, good information. And you may want to involve, as we mentioned, a palliative care specialist to help you make those decisions. You can check into hospice. And again, the recommendations are, instead of waiting until the last minute, to do this a bit earlier, perhaps 6 months before. You're not penalized if you outlast your 6 months. So there's nothing to be lost than using all of the support to help you live your life out fully at the end, to say the goodbyes you need to say, get coached with all of that, to have the comforts in place to be able to make that transition. Palliative care, as we mentioned. So let me talk about these two for a second. Voluntary stopping eating and drinking. So voluntary stopping eating and drinking is talked about more and more these days, because ultimately it gives us control over the end of our lives. It isn't so much the eating that does it, it's the drinking that does it. So if you stop eating, I mean, depending on what your state of nutrition was at the beginning of the end, you could last for months. On the other hand, if you stop drinking, then death will come within an average of 10 days. It can be 14 days, it can be 5 days, but again, it depends on the status of hydration when you start. It's, you know, it can be a long 10 days for a family. And so as we talk about medical aid in dying in a second, for some of us, we'll find that a more attractive option. But it is an option that's available to everyone legally everywhere. Now, there's been increasing discussion about the use of this in conditions that don't qualify for medical aid in dying, like dementia. So the reason dementia doesn't qualify is because it's slowly progressive. And by the time you get to where you're near the end, you no longer have mental competence or capacity to make independent decisions. However, if you say, and you do a dementia advance directive, and there are now specific advance directives for dementia, and you say, if I don't recognize anybody, and if I don't seem hungry or thirsty, please don't feed me. And that's okay, that's acceptable. Palliative sedation means intervention by a usually palliative care or hospice physician to provide sedation during the very end, especially if it's very uncomfortable. And again, the death is generally caused by dehydration. So it takes a number of days, but you're basically asleep during that. Medical aid in dying. So that's what we're going to spend a few minutes on, and then we'll stop for questions. We talked about Katie Butler. So she has a nice practical thing. She says, basically have a vision of how you want to die in peace, stay in charge and fire doctors who won't communicate with you, know the trajectory of your illness, ask the doctor to diagram it, arrange caregivers, create a tribe of people, a support system around you, seek earlier referrals to palliative care and hospice, tie up loose ends, say thank you, I love you, forgive me, goodbye, and transform a medical event, death and dying, into a rite of passage. All, I think, very wise, common sense advice. Steve Jobs, if today were the last day of my life, what would I want to do what I am about to do today? And Mary Oliver, what is it you plan to do with your wild and precious life? You know, there are times between diagnosis to disability during which people consider what treatments to try. And again, with the caution, do you want to use this time and risk making yourself a whole lot sicker in the hopes of longer term improvement? And again, you may want to seek guidance on this from like a palliative care doc. And then revise your prognosis by response, by how you respond. So if you respond well, you'll continue. If you don't respond well or have adverse effects, you might say, that's enough. Diana, in the holiday spirit. Life can be quite good during this phase. So what's on the bucket list? What would you like to do with your wild and crazy life? Whoops, what happened there? Oh, this is key. instead of hope for, what's going on here? For life or for cure, we need to redefine what we mean by hope. Hope for fulfillment, for meaning in our life, for family, for life, for humanity, for peace, for relief of suffering, for reconciliation, and so forth. So I wonder if it might be helpful to look at a 9-minute video on how the law is used in a state that has the law. And then we'll go back to talking about the specifics of the law, and then ask yourself whether it's something that I could do.
That sounds great. We've got the luxury of time here, so that.
Okay, great. So let's hope technology works. Pepper is 48 and had advanced breast cancer.
If we can't get the video, maybe you want to summarize for us what we would have seen?
You can't see the video?
No.
We are not seeing the video.
Oh, I'm sorry.
Can you see it, Ron? Is that it?
Nobody's seeing the video?
No.
No, we can't see it, Ron.
Let me try that one more time.
Okay.
You're not seeing that.
Unfortunately, no.
Okay, hang on. Sorry, it worked yesterday. Let's see.
This is where we need Joe Newman.
Let's see. Let me get off.
Is Joe at the doctor's today?
Yeah, he had some other commitment. I don't know if it was
One more.
his mother-in-law.
So let me get off this case presentation. So it should go to video. I have to get to the slide.
Well, we're not seeing your screen now either, Ron.
You're not seeing my screen. Okay. Let's get off this. I forgot to share the screen first. Okay, I think I'm getting there. So,
Ron, it
share
looked
screen.
like you clicked on the Word video, but not on the link itself. Maybe that was it.
Well, it worked for me, which was curious, which is why I thought you were seeing it. Hang on. Where is the, oh man. So you're not seeing that. One last time here, sorry. So, okay, share screen, PowerPoint. You see that?
Yeah, we see that.
You see the PowerPoint. Okay, I've got to get it to the screen part of the PowerPoint.
Oops. Lost it.
Let me unplug this one. I've got two. All right. Can you see that now?
Yes.
Okay, let's push that. Can you see that?
No,
No.
No?
no.
Sandy suggests punching in on the HTTP underline versus the video. Would that help?
That shouldn't matter, but let's see, because they both work.
Okay. No,
No.
no.
Okay.
Ron, is it possible you can send us out the link and we will try to get?
Yes, I can do that. I really would love to see you see it. Is the only issue. Let me try one last time. So can you see that slide?
Yes.
You can see that slide. All right. Let me try pushing that link and see if that works. How about that? Can you see that?
No.
Huh?
No.
Really, no.
So you're not seeing Arizona Town Hall meeting?
No, we're
No.
just seeing the
No.
slide, your slide.
We're still at the slide level.
Okay. I just don't know how to. Okay. All right. I guess I don't have any choice but to do it that way. That is weird. It worked really well yesterday.
Maybe it's
But you
only
can
on
see the
your
case.
computer, but maybe it can't work on a shared basis.
No, it did. It worked on a shared platform yesterday. So
Okay.
you see the case presentation, right?
Yes.
Yes.
That slide.
Yes.
Let's try it one last time.
Hold on. It may be.
Yes or no?
No.
No.
Okay. All right. Sorry about that.
Ron,
Oh, yes, dear.
are you supposed to double click on it or just single?
You know, it's perfect with me, but for whatever reason, I don't understand enough about how Zoom works. It's not sharing with you, so it's
Yeah.
working for me.
Yeah.
So, and yesterday, one of the other people was running the share, so I didn't have to mess with it. So, but in summary, this is a woman who's 48. She had advanced breast cancer. She'd been through multiple courses of treatment. She'd become more and more incapacitated by pain. She, in the month between when we met her, she became bedridden, essentially. And she decides, and she's still joking and happy to be around with family, but resolved in her decision that she just did not want to go on living this way and watch her body continue to deteriorate. And she wanted to maintain control. And she must have said that about 20 different ways, that having control over the way she wanted her life to end, as opposed to ceding control to the cancer that was ravaging her. That was why she proceeded. There was a bit of a ceremony just before everybody said goodbye. They had toasts. They cheered with tequila toasts. She took the medication, went to sleep, and died 3 hours later. So that essentially is her story. So what is medical aid in dying? Medical aid in dying is a medical practice in which a terminally ill, mentally capable adult, resident of the state with a prognosis of 6 months or less to live, has the option to request from their doctor a prescription for medication, which they can then choose to self-ingest to die peacefully. They and their doctors participate voluntarily. Mental capacity is assessed by physicians and referred to mental health people if it's in question. Hawaii is the one state that requires everyone who considers medical aid in dying to have a mental health assessment. Oops. Oh boy. Why is this not working? Okay. Wills, contracts, insurance, and annuity policies are not affected by a person choosing aid in dying. And medical aid in dying is not considered suicide or assisted suicide, which are against the law in most states. Probably no one has given more of a face to the medical aid in dying movement than Brittany Menard. You may remember her as a 29-year-old with glioblastoma, the same brain cancer that claimed John McCain. She had had aggressive treatment with surgery, chemo, and radiation, and then the cancer came back with a vengeance a couple of months later. She knew what the future would hold. It would be progressive neurologic deterioration leading to death. She was already having worsening seizures and intractable headaches. She said, "I don't want that. I'm going to move from California to Oregon." She came through Arizona, took a look at the Grand Canyon, and wrote about her decision. Her mother, Deb Ziegler, and her husband, Dan Diaz, helped pass MAID in California. These are the states where MAID is legal in the US. It started with Oregon, as you can see, in '97. And the most recent one is New Mexico, which the governor is going to sign the law, which was passed 2 weeks ago, into law tomorrow. So Maine, where I spend half the year, passed it in 2019. Views of medical aid in dying are clearly changing. In Arizona, there was a Gallup poll survey in 2015 that indicated that 56% of a randomly sampled population favored it. If you stratified that for seniors, it was 63%. Nationally, in 2020, 74% of people indicated support, with a majority of both liberals and conservatives. 70% of people who identified as Catholics supported it, 53% who identified as Christians supported it, and 84% who said they were non-religious supported it. So there's broad-based support for medical aid in dying by the public. Physicians are similar. In Arizona, we did a survey as part of our task force that indicated that 53% of the folks that we sampled were in favor, 27% were opposed, and 20% were undecided. And the US as a whole, a large sample, 8,000 doctors, 58% favored medical aid in dying. Some differences between suicide. The term for medical aid in dying is also assisted suicide, but there are some striking differences as to why this is very different from suicide. There's a terminal diagnosis. They're mentally competent to make decisions, whereas patients committing suicide are severely depressed. They want to live. Death is peaceful, planned, with family present, and grieving after is normal with closure. None of these may be true with suicide. A couple of other things. There's a timeline, and the timeline was designed in Oregon to assure that the decision was well thought out and to assure that there was no coercion. So here's what it is. First verbal request made to any physician documented the medical record. A second verbal request 2 weeks later, documented in the record, and a written request. Then a 48-hour waiting period between the written request and the time that the prescription can be dispensed. Now, several states, Oregon waived the 15-day waiting period in 2019 if, in the physician's opinion, the death was imminent and they may not last 15 days. And New Mexico, in its law, made two major changes. One, they permitted nurse practitioners to be one of the two providers because it's a rural state. So PAs and nurse practitioners can participate. And secondly, they also waived the waiting period. So theirs is 2 requests plus a written request and then a 48-hour period. How often is MAID used? It's an infrequent option. Less than 1% of deaths in Oregon occur as a result of MAID. In fact, only about 0.5% occur because of MAID. A higher number request the medication and keep it, but never use it. And a larger number are reassured by knowing that this is an option for them if that's what they choose. In real numbers, it's about 300 requests in 2019, about 200 used the medications in Oregon in 2019. The time to death was about an hour, ranging from a minute to 47 hours. Most people were over 65. The mean age was 74. The diagnosis for most was cancer, followed by neurologic disease, respiratory insufficiencies, heart disease, and so forth. 90% of people were enrolled in hospice, and 90% of deaths occurred at home. And here's something that's important. The primary reason for choosing MAID was the inability to enjoy life and the loss of autonomy or control and the perceived loss of dignity. And these were the three reasons that were cited 90% of the time. And in over 20 years, there have been no abuses of the Oregon law. The medications have changed somewhat currently, and I won't go into this unless you have questions about it. This is the one that's recommended. The goal is to have a short onset of action so people drift off to sleep quickly and to die within 2 hours and to be 100% effective. So that was the goal, and to be reasonably priced. Secobarb, which had been previously recommended, got priced to $5,000, $6,000, and then finally was discontinued altogether. So pre-treatment with drugs to prevent vomiting, digoxin, heart medicine, diazepam, Valium, morphine, amitriptyline, a tricyclic antidepressant, and phenobarbital. And that's the cocktail. It has to be mixed up by a pharmacist. So a compounding pharmacy has to participate. It has to be self-administered, but that can include oral, feeding tube, or even rectal tube. The rectal tube can be placed for this purpose, but has to be self-administered. The cost is about $800. There are private foundations that will help people who can't afford this pay for it if that's what they're choosing. The average time to sleep with this cocktail is about 6 to 8 minutes. The average time to death is about 1 to 2 hours. And more importantly, the longest period was about 5 hours. And there's now a group of physicians that do research and share information about the best medications. And lastly, just a curious comparison between the US and Canada. In the US, medical aid in dying is purely adults, resident of the state, terminally ill with less than 6 months to live, as certified by 2 physicians. You got to be mentally competent to give informed consent right to the end. Means that people like who have dementia can't qualify. They've got to be physically capable of self-administering medication, which means if you have a neurologic disease like ALS and you wait too long, you can't qualify. And there has to be a voluntary participation by providers. Whereas in Canada, it can be a physician or a nurse practitioner, and they can either administer the medication, which makes it euthanasia, or it can be self-administered. Mature minors, which goes down as young as 12 with evidence of maturity, serious incurable illness or disability in advanced state of decline, but there's no 6-month prognosis required. Patient is enduring physical or psychological suffering that is intolerable. The voluntary request, having been offered, and other means of relieving suffering have been tried, and voluntary participation. So I guess the questions we all have to ask ourselves is if it came to that, does this fit with what I believe? What if there's dissent within the family? We've already discussed how you wouldn't qualify if you had dementia in the US, or if you became too weak to swallow the medication. And yes, you can change your mind right up until the end. Our local organization, Arizona End of Life Options, the website is there, and there's lots of information, including this videotape. It's called The Town Hall. It was shown on Channel 12 a little over a year ago. Our national partners is Death with Dignity and Compassionate Choices. So I'm going to stop sharing the screen. And now, how much time have we got? Still a half hour. That's great. So let's see what questions.
Thank you. So,
arise.
people feel free to raise your hand or use the reactions and raise your hand. I see Lori Steen has a question, and Marie looks like she's got something on her mind.
No. Thanks, Ron, for that presentation, and thank you for heading up this effort in Arizona. I have in front of me I think you referred to the post as the orange document.
So Post is somewhat different, but they have similar purposes. The orange document is supposed to be on your refrigerator door so that if paramedics are called and you have an orange document, they can see it and know what your wishes were. The Post is something you'd carry with you if you got admitted to the hospital and would be incorporated into doctor's orders. Your primary physician should have it. And, you know, so
Okay,
it's slightly
and then
different.
at what point in your life should you fill these out?
Late, so last 6 months.
Okay. Okay, thank you.
Marie, you look like you were wanting to.
Well, this isn't directly on this. I was just wondering the chronology when you said that palliative care has only been around for about 12 years. How long has hospice been around? It hasn't.
So hospice started in the late 60s in England and came over to the US in the early 70s. So it's really since the 70s. And if you look at where people died, I alluded to that. Most people, you know, around 1900 died at home of sudden illness. You know, they had heart attacks or they got accidents or injuries or one thing or another, in epidemics, flu and so forth. Whereas by the mid 50s, when my mother passed, most people died in hospitals. And then with the growth of the hospice movement in the 60s and into the 70s in the US, fortunately, most people are now dying at hospice, either at home or at hospice. So hospital deaths are now about 20% or 30%. Frank.
Yes, Frank.
Two things. On the one of the slides that you were describing the difference between MAID and suicide. One of the comments was, oh shoot, let me close the door and get my dog. One of the comments was under MAID is the individual wants to live. And so that seems to be a dichotomy of, well, why do you want MAID if you want to live?
Because you don't want to die, the illness is killing you. You don't want to suffer, which is why you consider MAID.
It was saying, I want to live. Why would you put that under medical aid in dying when the person says, I want to live?
Well, I think it's that if it weren't for the illness, I think that they wouldn't be opting for this. But I think that it's the illness that's robbing them of meaning in life. Again, I think people were surprised to find that it wasn't so much pain. I think hospice has done a great job and palliative care has done a great job with pain control. But it's this notion that the way things are, what I can't do anymore is enjoy my life. And under those circumstances, I don't want it to go on. So I'll entertain ending my suffering.
The second question I guess I have is, for the doctors who object to MAID, did they give any reasons why they object to MAID?
So you're talking about in the Arizona survey?
Yes.
Yeah, so we also asked them to explain their answers, and hundreds of people gave answers on both sides. So religious beliefs were strong, especially among Catholics. Although there were certainly some Catholics who said, I've been a Catholic my whole life, but I strongly believe in this option.
No, I'm asking about the doctors.
Yeah, they're talking about doctors. These are doctors. Okay, these are all doctors. Yep. The other is a doctor, some doctors felt like it violates the Hippocratic Oath. Now you have to recognize that the Hippocratic Oath, of course, was Hippocrates and whatever that was, BC. I mean, many thousands of years ago. Medicine has certainly changed a little since then. Most medical students do not take the Hippocratic Oath, and those that do take a modified version that has to do with respect for the patient, listening to the patient, providing comfort, and so forth. But the line that is cited in the Hippocratic Oath is, I will give no poison to any patient. And that was the original Hippocratic Oath. So for some, they feel it violates that element of trust that the patient has with the physician. Now, again, those of us that feel differently believe that providing comfort is the most important thing, that if we can prevent a disease, great. If we can cure a disease, great. If we can't do either, then at least provide comfort. And for some, that comfort might extend to including this modality if it's legal in the state. I would have a great deal of difficulty if it were not legal. Certainly medical people have been brought up in charges in other states. It puts families at risk and doctors at risk. So I certainly wouldn't. And in states that where it is legal, I think that the physicians feel very positive towards their involvement and not feeling like they're abandoning their patient at their most vulnerable moment of need. So, others, there was an editorial in one of the medical journals just the other day. Diane Meyer, one of the giants in the field of palliative care, felt that this raised a slippery slope, that if you allowed this to happen, then, they would cite evidence like Mengele in World War II, where we take undesirable people, people with disabilities, or people who, for whatever reason. But that's very far afield from this, which relies on careful information, a well thought out plan, and really is very much different than this. So I think the concern that it could extend to other things, Diane Meyer's point was she believes in the concept, but she doesn't feel it can be carried out without risk. But there are now 10 states. Oregon's had the longest experience, but other states together have probably over 60 years of combined experience without abuse. So I think it can be done. I think it can be done well and safely. It's not for everyone. And as you can see, a very small number. Now, interestingly, in Canada, I think I mentioned to you that they have euthanasia, as they do in some of the European countries. About 4% of deaths in Canada occur from euthanasia, but it's still only 0.5% from self-administered MAID. So given the choice in Canada between having a physician administer the medication directly or provide it for you in liquid form, most people will choose to have it administered IV. Sandy.
Yeah, Ron, I think I heard you say that Canada allows MAID for people with Alzheimer's, is that right?
I believe that is the case. It is an evolving thing. So what is, as I said, what is legal here is advanced directives that say, if I get to a place where I don't want to eat, don't force feed me. Because in a lot of nursing facilities, they will force feed people with dementia. So that is possible in the US. In Canada, there is talk, and I don't know if it's actually been implemented, that would allow you to choose assisted dying via euthanasia when you're still mentally competent to make those decisions. As we said in the US, it's not possible because by the time you're close to death, you're no longer mentally competent.
Yeah, I wanted to raise this topic because a few days ago, I think it was in Sunday's paper, there was a very poignant article by E.J. Montini about his wife. Maurice nodding.
Mm-hmm.
It was called Driving My Wife to the Afterlife. And it's kind of an interesting topic. So I started reading it. Essentially, his wife has had Alzheimer's for several years, and she's at the point where she doesn't even know who he is.
Right.
And it got to the point where she couldn't live at home. And so he was driving her, telling her he was taking her for treatment, but basically she was never coming home again. And it was going to be her afterlife, essentially. It was very, very sad. And he describes what a vital, intelligent woman she was, and all of the things she did in her life, and that there would be no way she would want to be living like this. And so I thought about your speech coming up, and I was thinking of raising that, and then it occurred to me that how does she have the capacity, the competency to request it? But on the other hand, if the option is having an advance directive where you talk about Alzheimer's, and you can at least say that, but I have to say that I experienced my mom go through the voluntary stopping of eating and drinking. I don't know if it was really voluntary. She just had no appetite at the end. She also had dementia, but it was like a long process. It took a little bit over about a week, and it was heart-wrenching for the family to sit there constantly and stay with her. It was just awful. So in the end, she died alone, and I just think that is not a satisfactory solution, but I don't know what is really.
Yeah, it's you have to counsel people that it takes that amount of time. As I mentioned in this friend earlier, whose husband passed recently, she knew that it was going to be about 10 days. I think it was pretty close to that, 8 or 9 days. And, the family gathered and was very supportive. And so there wasn't, but it can be difficult. It can be modified with, it's best if it's done in conjunction with hospice, and and if sedation is needed through some of that can then be provided. Bonnie, you want to talk about the Jewish position on this? Because you and I have talked about that a few times. And
Lori has a hand up too. Go ahead, Lori.
You may be alluding to, Ron, the document that I have that Rabbi Capel sent. I think it's called, the Jewish Medical Directives from a conservative viewpoint. But my question is, I have a living will through my attorney. I have the Secretary of State's advance directives, and I have this document that Rabbi Capel sent me. And it more specifically gives my last wishes. And I'm wondering, should I file all of those with the Secretary of State, or one or two of them, or what do you?
I don't know how that works. And as I said, it's going to move from the Secretary of State to the Health Information Exchange sometime this spring. So I'm not sure what they have the capacity to store, whether you need just their documents, or I don't really know about that. I think the most important thing is to have the people that are most in touch with you know about their existence, about their content, and especially the person who you appoint as your proxy, who's going to speak for you if you can't speak for yourself. That person needs to know what your wishes are. Some people have recommended videotaping, making a short video of what our wishes, what our end of life wishes are. And some have taken a more positive approach, towards leaving a legacy, in terms of, but there are different approaches that have been taken by.
Okay, and it's called the Health Information.
Health Information Exchange.
And they may be the entity that takes over from the Secretary of State.
That's what I've heard.
Thank you.
Any other questions or comments from the group? So Ron, I wanted to share with you, we had a conversation with Laura Geller, Rabbi Laura Geller recently, who wrote the book, Getting Good at Getting Older. And it was, she was motivated to write that book based on interviews with over 200 congregants in parlor meetings that were conducted in her congregation. And I'm quite interested to know that they identified 4 primary fears that people had at the end of life. So they were the fear of being invisible, the fear of being isolated, the fear of being without purpose, and the fear of becoming dependent. And I thought it was interesting that she did not find evidence in her survey of the fear of suffering, which I think is so primary for so many of us as a. When we look at this from the perspective of Jewish tradition and Jewish practice, we need to recognize that the rabbis are formulating an approach to end-of-life issues 2,000 years ago, when life expectancy and medical treatment were not what they are today. So it's very challenging to take classic Jewish sources and apply them to our lives today. I often think of my own example that I had pneumonia in my late 30s. And in a previous generation, that would have been the end of my life. I, had already reproduced, and that was the purpose of my life, and it would have been the end of my life. And here I am now, 30 years later. So it's not exactly an apples to apples comparison, but I can say as a general guideline, Judaism has always allowed for not intervening to artificially extend a person's life while not permitting us to artificially hasten death. So I think medical aid in dying would fall under that category, because we're taking someone who does have a life-limiting diagnosis, is going to die, and we're accelerating that process. So I'm imagining that an Orthodox rabbi would not be in favor of medical aid in dying, but I haven't investigated that. That would be an interesting question to raise with some of our Orthodox colleagues. I think in the non-Orthodox world, there is a gaining acceptance of this option. And it certainly has been an evolution in my own thinking on this. I think that Dr. Ron Fischler and I have been in conversation about this for probably at least 10 years. And he's well aware of the evolution of my own thinking, also based on my experience of watching my own husband's suffering and dying. And in the case of David, as I've mentioned previously, I feel that I personally suffered from a lack of information from the oncologist that might have enabled David and I together to make different choices than we actually did make. And to me, that's one of the critical takeaways of the presentation that we've seen today, is that knowing that we have a limited amount of time available, how do we want to spend that time? Do we want to spend that time enjoying the time that we have, or do we want to spend it in the hope that we might fight for more time that may not be quite as enjoyable as we would have envisioned? Another point I just want to emphasize from the presentation is Dr. Fischler spoke about the aspect of hope, that we need to redefine what hope means. And I think that that's something really important for us to all think about. It's meaningful when we say the Misha Berach prayer, that we ask for healing, but we don't necessarily define healing as the illness is going to go away. Healing can mean coming to peaceful terms with the time that we have and the limitations that we may experience during that time, and how we can make the best use of the time with which we are blessed.
Well, Ron, I still think about your parting words of, you are hoping for a soft landing.
Right.
I say that quite a bit to people.
Right.
Yeah, it's beautifully said. And I have to tell you, just anecdotally, I had a conversation within the last 2 days with a woman in our congregation. She has, her mom has dementia. Her mom clearly articulated that it would not be her desire to live in the state in which she finds herself. And our congregant has 2 sisters. one of whom is in support of not continuing artificial nutrition and hydration because they sense that that is aligned with what mom's wishes were. And then there's, I dare say, almost the inevitable third child who has not been as actively connected to mom and now is experiencing a great sense of guilt about that and is wanting to impede the other two daughters' ability to move forward with fulfilling their mom's wishes. So this is a real life considerations that we're dealing with.
Which is why it's so important to record what those wishes are in advance, so that the daughters, the dutiful daughters, are basically supporting the mother's wishes, not inferring what they think their mother would have wanted.
Right.
Which sets up a conflict within the family, but are simply acting on her mother's wishes. Is there a feeding tube in place? You said.
I don't know about that.
Okay. So again, most folks would not want a feeding tube inserted in a patient with dementia for the reasons that were just alluded to. It would postpone the inevitable by a very long time.
Ron,
Sandy.
I wonder if you could just give us a little summation of what the status is in Arizona. I would imagine, based on the abortion legislation that's going through, and that it would not be very positive towards getting MAID approved in Arizona, but I don't know.
Right. So last year, many of us were very hopeful that there would be not only a democratic shift at the national level, but also at the local level. As you may know, the legislature is leaning Republican, meaning that there are more Republicans in the legislature than there are Democrats. The way politics works in Arizona, at least, is if a bill is brought up, it is sent to committee. The committee chair is a member of the dominant party. So whichever party is in power, that chair belongs to that person. Unless there's bipartisan support. And in recent years, there have been no Republicans that are willing to stand up in favor of medical aid and die. That it's not likely to happen until there is either a Democratic shift or we get a few Republicans willing to stand up, because bad deaths do not follow political party, but they are pretty much under the throes of the religious right. And the concern that we have is, of course, that we're respecting other people to allow their religious beliefs to define what they do, but don't foist your beliefs, on us. So I am a proud member of the secular coalition to try to separate, church and state. I think we're trying to get, Republicans to support it. We're trying to form coalitions with various groups to lend support to it. Lawyers have been identified as a group in the New Mexico passage of the law. The two most persuasive people were the lawyer who was a professor at the University of New Mexico who spoke, and a physician who was a very respected member of the community. So those two, plus a lot of storytellers, a lot of people, including the daughter of one of the lead sponsors who had 20 years of cancer and wanted this option for herself. So, but New Mexico is a different state. They have a Democratic governor, and they now have a Democratic legislature, both houses of the legislature. So it's either going to take a Democratic majority in the next election, and it's only 1 or 2 seats away in both chambers. We also would face challenges with Governor Ducey, partly because he's Catholic, partly because he is probably not going to favor this kind of legislation. But we can be hopeful that whoever succeeds Ducey, and perhaps if that's a Democrat, Katie Hobbs or whoever, might be in favor. So I think we are sort of trying to spread the word, educate people about what's involved, try to identify people who have stories to tell, appeal to certain constituency groups that might be influential in talking to legislators down the road. But if any of you know any Republican legislators or Republicans willing to talk to their legislator, that would be very, very helpful at this point. We have an organization. I'd love to, have any of you who wish to join with us in that effort, and I could certainly help you find something meaningful to do. But it's basically contacting legislators who make this decision. The Democrats are generally in favor. The Republicans uniformly against.
Thank you so much. Marie said she had another commitment. She's signing off. Lori, I'm going to give you the last word and then we'll wrap up.
Thank you so much. I have the dementia provision, Ron. The advanced directive addendum. Do I file that with the Secretary of State? Do I just give it to my family?
I do both. Again, I don't know what forms, how many forms, what type the Secretary of State will collect. In Arizona, I'm told that it's called the mental health power of attorney, which applies to dementia. But I think the form you have, which is probably Compassionate Choices or one of those, is probably adequate. Certainly for your family, certainly to advise your proxy on what your wishes are.
Okay, thank you.
Where do you acquire all these forms, Ron? I'm sorry to ask you a question, but.
So Compassionate Choices has a whole series of them. There's a group in Arizona called Thoughtful Life Conversations. One of our trainings that we conducted at Temple High was done under their auspices. They have all of these forms on their website, so they're easily downloadable.
Okay.
Also, there
Andy?
are a set of forms on the Attorney General's website that there are good for Arizona.
Right.
So
Thank you, Ron.
up in the chat as well, the link for tonight's program at 7 p.m. Please join us if you are able. This is a medical school colleague of Alan Maltz, who wrote a book called Not Just a Survivor. We are commemorating Yom HaShoah, and Dr. Roisin Miller will be sharing her mom's story and lessons about resilience from her mom's story. That'll be at 7 o'clock tonight. So if you
One other thing that's coming up is Diane Rehm, who's become quite an advocate for medical aid in dying based on walking with her husband through the last part of his life from dementia related to Parkinson's. She spoke at Changing Hands, I think, a year or two ago, and is now taking this show on the road. It's going to be shown on PBS. There are multiple showings in the next couple of weeks, so look for that.
What's it called?
Rabbi, is that going to be recorded tonight by chance?
I think I will try to record it, yes.
That'd be great. Thank you.
It's on my desktop, but I got to get rid of this Zoom thing, so I might lose you if I did that. So
Okay, I'll get it
I
later.
can't remember. It's the same title as her book. So,
Okay, I got it.
but Diane Rehm PBS, I think if you Google that. And again, our website, which has that video that we were unable to see, is www.azendoflifeoptions.org. And you're looking for the town hall video, and the first 9 minutes are what you want to see.
Thank you once again. It was an
Thank you, Juan. Thank you.
presentation.
You're very welcome. Nice to meet with you all. Thanks.
Thank you.
In this area. Nice to see everybody.